Hello, my name's Richard Bing. I'm a general practitioner, have been for 23 years, and welcome to learning from the DeStress Project. I'm going to give you some of the key insights that we've gained from a really great project down in the West Country, where we've worked with some communities in resource-poor areas to think about what we do as GPs, working with those communities and how we can improve that. So, as you'll probably know, general practice is often the first port of call for individuals with mental health problems suffering from distress. And it's our job in general practice to receive, recognise and diagnose individuals who have what might be called common mental health problems, anxiety and distress. So this project is set in the context of austerity and welfare reform, which we know has led to an increase in distress. Alongside that, we've got an increase in the use of mental disorders as terms used in the general population. People are being diagnosed with depression, anxiety, and this seems to be framed as a psychological individual problem rather than a problem that's generated by circumstances. This implies that there must be a treatment that can be used to fix an individual and really masks the root causes of suffering: social isolation, low pay, unemployment, trauma. So I really like this heat map which shows where antidepressant prescribing is highest. What's interesting is that it's not London and the big urban centres where you've got most of the high rates of prescribing. It's post-industrial, poor, white, stable, rural and coastal towns predominantly. Blackpool is the peak, and 1 in 2 adults had a prescription for antidepressants last year at some point during the year. So the aims of this particular project are to understand the narratives of medicalisation. That's how we talk about poverty-related distress, and to understand the challenges facing GPs supporting low-income patients. And this particular presentation, I want to tell you about what we've learnt about what might be good practice in supporting individual patients. So what have we done to create this learning? We've worked with 2 communities, so this has been engaged research. We've had individuals from the communities working alongside us, actually supporting the direction of this particular work. They were really keen that we did some training materials for GPs. We had focus groups and interviews, and we've interviewed GPs, and we also used conversation analysis to really go into the depth of what happens in consultations, using video of those consultations and then analysing line by line. We then delivered some workshops to GPs and GPs in training and reflected on the interaction to really understand the difficult concepts that need to be understood by individual practitioners if you're going to change practice. So those are the bits I want to focus on. So before talking about the results and the main conclusions, I want to show some videos which were produced by the community partners, and these demonstrate really clearly some of the key issues that we will be looking at in a minute.
Should I go and see them, or should I just not bother? The thought of that, I think I'm wasting the doctor's time, or that there's people in front of me who've got worse conditions that, again, it just boils down to the wasting time part of it, not being judged. I mean, I'm not dying, I'm not dead. I can cope with it, It's like having a cold. You just get up, you get on, you don't worry about it. Also, I don't know. Going to the doctor about depression, it's not something you can see. It's not like I've got a broken arm or I've got a cold or anything like that. You know what I mean? I wouldn't you know, it seems to me like it's pointless, and it's why would you say that? Why would you even think about saying that to someone, especially a professional? Because they're just going to think straight away, well, you're an idiot, go away. It is a small problem. In the grander scheme of things, it's a small problem. I mean, I think to myself, well, what is a GP gonna give me for it? You know, is he gonna give me money to sort my money issues? Is he gonna give me, you know, things to cheer my children up, or things to make my partner happier? Is that what he's gonna give me, or what's he gonna do? So why, you know, he don't really care. I'm just another one of these people who say they got depression. I can't prove it. How am I going to prove it? There's not like a test you can do, is there, to prove it? It's just how you feel, and explaining how you feel to especially to a doctor is difficult, because it's someone that you don't know. It's a stranger, you know. And talking about your emotions and your feelings, especially when your emotions and your feelings are up and down like a roller coaster. How do you present that to someone, especially to a professional who knows, well, supposed to know a lot about depression? How do you do that?
Okay, so previously when I was 16, I went to a GP, and it was a total opposite experience than what I had recently. He was really standoffish, and when I was explaining stuff to him, he basically just asked me if I felt like killing myself. If I didn't feel like killing myself, then that was not a big issue. And that when I told him why I felt the way I felt, he said that's life, and you're just going to have to learn to get over it. I felt like he obviously knew best, and that I couldn't challenge him. I couldn't say that, actually, I think you're being really black and white about the situation, and not every person that's got anxiety and depression wants to kill themselves. I couldn't say that to him. I just thought, right, okay, well, obviously I'm not as bad as what I need to be to get some help. And he made me feel really uncomfortable, like I couldn't say what I needed to say, really. So basically when I come out of there, I felt like I was dramatising everything, felt worse than I did before I went in there, and I got no help anyway. So I just thought all GPs were like that with mental health, and it took me until I was 29 to think about going back to the GP, and until I was 30 to actually go and see another one. And that was all because I had that really bad experience when I was 16. A couple of days before, I'd think, oh, actually I'm not as bad as I thought I was, so I'd ring them back up and say I didn't need the appointment anymore, because I thought initially that they would judge me and think that I was crazy and that all my thought processes were irrational, which I knew anyway, but I just couldn't stop it, overthinking things. And they would say, oh, you're not a good mum, basically, and they'd take my kids. Panicky and nervous. And I thought that I actually said to her that at the end of it, that I thought she was going to put me in a straitjacket, because I knew the things that I was thinking were so irrational, and there was no logicalness to it at all. She made me feel comfortable, to be honest. And she turned to me and greeted me, and she was really made me feel comfortable, let me talk about my feelings and stuff. And when she was telling me about what she was going to offer me, she took on board what I was saying. So she offered me counselling, but I was just truthful and said that I probably wouldn't turn up, because phoning her was a big enough anxiety for me, let alone going to talk to somebody I didn't know. So she wrote down some books that she thought that was a good idea, like self-help books and stuff. And then put me on some medication that turned out to be the right one, so I was lucky. I do feel that it was the right choice for me, because I've had this anxiety, depression, if you like, for quite a few years, and I knew that it got to the point now where I couldn't pick myself back up again. So I did go to a doctor to actually get some medication, to be honest, to help me get through this really bad phase that I was going through. And I did feel like I could challenge her if I didn't want to go to medication straight away, because I challenged her on the counselling thing and she did listen to me, and it wasn't like an argument or anything. She just took my feelings on board and just moved on to the next thing that she thought was appropriate.
I'd become severely depressed. I was becoming agoraphobic, didn't want to go out, wasn't looking after myself. I was just hiding away. I knew that I wasn't right. I knew I wasn't myself, if you like. Normally I'm very chatty, very amiable to get on with. So my wife convinced me to go and see the doctor. Well, say convinced me, she bullied me. So did the kids. Really convinced me to go and see, because it was affecting them as much as it was me. But I didn't see that. I think I can sort of remember saying there was nothing wrong. I was a bit worried that she'd think I was faking. I'd never been to see anybody about anything psychological. Everything else had been physical. And when I went, I was, what's the word? Anxious. I was trepidatious. I went to go in and admit that there was something wrong with me. So that was the first step of going in and talking about it. I put it off for a few times to actually go in and saying that I needed an appointment to see doctors. One reason, because I didn't want to tell the receptionist what it was. That was in my mind. I didn't want to talk to the receptionist about it. They made the appointment, I think it was in a couple of weeks of making it, but I was still really nervous of going in because I didn't think I was ill. That was it. I didn't feel that I was ill, but other people around me could see it. And it was the even admitting to doctors that there was something wrong. That was really hard. She's one of the best doctors I've ever seen. And came in and I told her what was up. And she sat facing me, looking at me. I was looking down and she told me to lift my head up and look at me, and she held my fingers, and I was in tears. And she was very comforting was the word, very friendly, and she said that she had noticed that there was a change from when I'd first gone in, and that I had been getting more and more depressed. And then it was a case of, once she'd done that and she got me settled, she says, right, let's get something done about this. And then she went and did her medical bit, if you like. But at first she was very friendly. She wasn't condescending. She actually looked at me. She listened to what I'd got to say, and I'd say she took it all on board. She obviously knew that was something, because she's known me for quite a few years now.
So I hope that you can see the kind of issues that we're going to be dealing with from those videos. What's really clear is that the individuals involved have really thought about their experiences and have been able to teach us something new. And together with the conversation analysis and the interviews with GPs, we've brought together some key themes. Now, we've only got a few minutes here, but I'd like to start by just introducing some of the key themes. First of all, this is a system in stress, both for patients and practitioners. Part of that is the kind of pervasive and toxic nature of moral narratives. And that's narratives that are being discussed by families and communities rather than specifically by GPs, but also by other services. And what this means is that people start to feel that they can't trust each other, or they can't trust the authorities, and there may be a reduced willingness to seek support, as in this quote. But despite this, GPs remain one of the few services available. There are pressures on patients to legitimise their stress. So there's medicalisation, which becomes necessary if you're going to gain the benefits that you need to manage, to get housing support, to get the right kind of support to be able to look after yourself, look after your family. And what that means is that you end up having to take on a defective status rather than taking control. And that's clearly something that we all see as practitioners, this tension that individuals are facing when they come and talk to us. So, for example, they might see that they need to show that they're taking medication, that they have a diagnosis, but that's not what they really want. We also found that GPs have quite a dissatisfaction with the medical role. They know that they are medicalising social and structural issues, and the dilemmas that GPs are facing as gatekeepers to welfare are not welcomed by the GPs themselves. So one of the paradoxes of practice at the moment is that antidepressants become the default, and we are told to worry about adherence. We're told to worry that people need to be told to take their medication and make sure they take it for 6 months, because we know that there's sporadic use and people don't take their medication to time. And yet we also know that there's this continual rise, and that's because more people are staying on their antidepressants, even though a lot are stopping. So we've got a problem both ways. So people are uncertain about whether to take the medication and might not use them very sensibly, but many people stay on them way beyond the time they should, leading to this problem of 70 million prescriptions of antidepressants annually. So what are we going to do about this? We need to find a third way between blaming people and telling them they're useless. That's the neoliberal kind of attitude that they need to buck up. But also, we don't want to go down the route of medicalising everything, denying people's agency for contributing to their own well-being. How do we create a middle way as practitioners that understands that distress is caused to some extent by the situation people are in, but doesn't immediately shift to a medical response of fixing. So I think that the kind of proposed shift that we've talked through with our partners and developed, it's not rocket science. Hopefully it makes sense to most practitioners. It's absolutely clear that the GP-patient connection and trust is vital in consultations. You've seen that from the videos. Continuity is valued mostly by both parties, particularly when there's a good relationship. We need to find ways of demonstrating respect and a common humanity, because without that, people can feel that we don't really care, and it's very easy to fall into to say something, some small utterance or a look, turning to the computer, which means that the patients don't trust us. I think we need to review the logic behind the NICE approach, and we need to move to a supporting role that recognises the biopsychosocial whole rather than seeing depression or anxiety as faults that need fixing with medication. And lastly, we need to promote opportunities for non-medical forms of support. Much of that sounds fairly straightforward, and indeed, when we did the workshops, what we found is that most GPs and GP trainees had found empathy is helpful. Of course, that's obvious. Social problems, trauma, and humiliation lead to mental health problems. People don't have a problem in understanding that. Also that mental health problems can lead themselves to social problems. And even that mental health diagnoses can change over time. We've all seen how someone is diagnosed with one thing and then another. And practitioners know that medication and CBT don't always work because they have that experience. And certainly they know that it can be stressful supporting people in distress. What we were more interested in is working in those areas which are more difficult to take on board. And it was interesting that the workshops showed quite clearly those areas where it was trickier for people to understand. So we've termed these the key difficult concepts. So first of all, understanding that there could be a middle way between dismissing socially derived distress as not our problem and medicalising all distress. I think that needs to be at the core of an understanding of every individual. And it's both about understanding what their situation is, but also building a relationship with them. So we're not treating patients as things to be fixed, but neither are we treating them as not our business. Secondly, that diagnostic disorders are imperfect models rather than specific entities. We've started talking about depression as if it's a thing. Depression isn't a thing, it's a diagnostic model which relates to 4 out of 8 experiences in the last 2 weeks. Now, it might be quite useful and some patients like it, but what we need to be clear about is that it's something that we don't have to hold as a thing that people take on and become. It's just a model for understanding ourselves, and it may be that there are better models for understanding ourselves. Another key concept is the idea that we don't know what someone else is thinking, so we can imagine what someone is thinking, and we're very good at that as humans, but we can't be sure. So for that reason, we can also imagine that even though we're behaving very nicely towards them, they might still be thinking that we think that they're not worth it or useless. So knowing that people might have a range of thoughts about what we're thinking, it means that we can develop strategies to show that we aren't thinking those things. So just things like using we when we're talking about what happens with psychological processes, or congratulating someone on doing something that is difficult for them, and you're demonstrating that you're showing that in a non-paternalistic way. And then perhaps the trickiest thing of all for doctors is to believe it's okay that we don't have to fix everything. Part of the problem we have is that we've been taught that we diagnose and then we treat. And that works great for cataracts, but when we don't have very effective treatments, and neither CBT or antidepressants are very effective, we can't con people into thinking that we're going to get them better. We can work alongside them, we can be there, we can hopefully identify small changes that will make a difference. But often what patients have said is that it's more important that someone is there with them rather than trying to fix them. Related to that is that it's okay to have a balanced view of the harms and uncertainties, particularly of medication. So we can talk about that we don't know the long-term effects of medication, that only 1 in 8 individuals will really benefit from medication. That's being clear and honest about the evidence. Whereas I've stopped saying now, well, it's likely that you'll get better if you take these, which wasn't a lie, but it wasn't the whole truth. And lastly, it's important to work on personal strategies to deal with witnessing distress. We deal with a lot when we're doing a clinic, you've got 15 to 20 people that you might talk to or see in a morning. Amongst those are going to be several who have got quite difficult distress and difficult stories, and we need to admit that it's okay to work on personal strategies to deal with that. So how can we bring all this together in some kind of reconstructed model? I think there are three important things. Firstly, really engaging at a human level. Secondly, a shift from diagnosis to understanding. And thirdly, thinking that we can make small differences in multiple ways rather than fix a problem. So how might these be manifest in our everyday consultations? I think one of the first things is just appreciating that it takes courage to attend. Again, knowing that we don't know what someone is thinking and developing strategies to help patients see that you respect them. Listening and understanding will provide clues as to what interventions may be important. And actually there's a kind of clinical logic to that, that when you have something like antidepressants that have a small average effect, and you don't know whether they're going to work for the individual, then the evidence from that individual about what works for them in their past and what they think might work is much more compelling. The other thing I've got quite interested in recently is the role of neuroscience, and I think it's just been so helpful for me to go back to a scientific basis for understanding what we're doing. So instead of depression just being a kind of tick box exercise, you collect the symptoms, you equate that to a diagnosis, and you give people CBT or antidepressants, as in the NICE model for depression. Actually thinking about the science behind what's happening to both ourselves as practitioners and individuals can be really helpful and can help people to understand what's happening. So some of the key concepts: first of all, theory of mind, that we can only guess others' thoughts and beliefs. Really important to be aware of that. Secondly, that anger and anxiety are forms of a heightened emotional arousal, whereas kind of withdrawal is a lowering of emotional arousal, and the green zone in the middle where you can think clearly is where you want to be, but both anxiety and anger or withdrawal can mean you don't think very clearly. So that's a really important thing that we're not taught as doctors, but the neuroscientists have understood. Then there's genetic inheritance. So we are taught about looking at family history, but actually it's probably more important to think of it in a subtle way, so that we're constrained by our genetic inheritance. We're not completely controlled by it, so it's not that the genes will predict exactly how our mental health problems emerge, but clearly they have an influence, and also some people have a tendency towards being more anxious and perfectionists, or more relaxed, both of which can have positive and negative issues. I think it's really important to think of the brain and our social context as highly connected. So when we are living in the social world around us, the relationships, the power structures, that has an effect on how our brain functions. So it's not mainly the other way around. The brain is an amazing substrate for absorbing the effects of society around us. And this is nowhere more important than with trauma and loss. So our past traumas, loss, neglect, and humiliation affect how our brain works. And they together are responsible for most of the emotional ups and downs, the cognitive functions and problems, our negative self-concepts, our paranoia, and also some perceptual disturbances as well, so flashbacks, voices, dissociative experiences. Now, hope. Brain plasticity is the counter to the genetic inheritance. So while we might have predispositions, our brain is incredibly changeable and plastic. And this provides hope. We can always identify something that has changed in the last 6 months. And you can ask your patients, what have you done differently and developed a new habit of doing? And that demonstrates to people that they can change. So going back to theory of mind, where we started thinking about what our ability to think about other people, theory of mind is also about our ability to notice our own emotions. So recognizing our own distress as practitioners should be a fundamental part of practicing. So thinking about putting this together in terms of for resource poor communities, I would say that there are kind of two main propositions. Firstly, that a biopsychosocial model of understanding for each individual should take precedent over diagnosis, and that this helps direct individuals to engage with the thing that's most likely to make a difference. So in the British Journal of General Practice article, we have developed a model that brings these together. So in any conversation or over a series of consultations that might focus on thoughts and emotions of an individual, we need to think about the relationship between our thinking and emotional patterns and pain and physical health, our current social situation, and our actions and behaviours. And all of these things are interrelated in very complex ways. And that's not to say you're going to be able to make a complex model for everyone, but it is worth thinking about all of these things and bearing these 5 domains in your mind when you're having conversations. So this means that if you put all of this together, you can move from being a fixer to working together to make small differences, generate trust, create a shared understanding, accept you can't fix everything, work together with the patient to find out what might help, and then work as part of a wider team with and around the patient. So that brings us to our second proposition, that individuals, communities, family doctors, third sector, charities and mental health providers should work collaboratively to ensure individuals and the population can generate well-being through psychological, social and medical interventions working together, often and generally not using diagnosis or resorting to medication. Some fun diagrams to finish off. This shows where we're at now with unsupported self-care and people often being rejected by mental health services, resorting often to medication and isolated, unsupported community resources. And what we need to move to are mental health services supporting providers within the community, a whole range of supported self-care options, and GPs and patients with time to see each other, and medication less often prescribed. So finally, I'd just like to point out that we have some materials available, and you can have a look through the more detailed curriculum. Thanks very much.